Chairman, Mr. Adams. Mr. Adams, you go in the front row, sir. Also, we have our judges. We're judges of the Chief District Court Judge Tony King is here, as well as our fellow Judge Simon Mack somewhere. I see her. Any of the elected officials, make sure we acknowledge their presence today.
Assistant Director of Legal Services and Department of Justice.
Hey, I'm Sam Flashman, Chief Medical Officer, Fayetteville, Alabama.
I am Lisa Mitchell, and I am with Alliance Consumer Family Advocacy Committee.
Good afternoon, I'm Board Director for the
I'm Devin Coleman, Associate Superintendent for Garland County Schools.
Elon, Safety and Security of County Schools. Bridget Jackson, for the County Department of Social Services Director.
Good afternoon, my name is Jim Miller. I am a staff attorney and director of Alternative Law Program Advocacy and Expertise.
Good afternoon, I'm Mike Dahl, I'm the chair of the Juvenile Prosecution Council here with
I'm Krista Lawyer, Assistant Director of Social Work Services with Garland County DSS.
Good afternoon, Jerry Brown, Chair of the Fayetteville County Consumer Healthcare Homeowners.
Good afternoon, Brett Neal, Southeast Regional Advocacy Association.
Good afternoon, I'm the Chairman of the District Chief here at State University.
Good afternoon, Jim Ray, Chief Police for the City of Fayetteville.
All right, let's go all on panelists. This is a round of applause. So today, as you see, we want to dive right into this. I am so pleased to see the collaboration between the city, county, hospital, school board representatives, as well as our judges, juvenile justice, health department, social services. We brought all of the institutional stakeholders to the table as we talk about not only public safety, but truly public health in our community. And today, we're pleased to have Dr. Taylor, who's expertise, who's a leader on the state level in this team, to facilitate today's meeting. So I will keep the welcome short, and I'll turn it over to Dr. Taylor.
Good afternoon, and thank you, Mr. Mayor, all the elected officials, all of our community partners. As the mayor was talking earlier today, would be that when we talk about a whole government and whole community approach, the violence prevention, it is many of the people in this room, on this side, on that side of the community driving, and many more people who may not be here, but hopefully will feel the positive impacts of this work. I want to set kind of foundation that the things that we are working to do is to serve those who are often the most vulnerable, the most in need, and those who have been for generations at the highest risk to be victimized by crime, violence, and trauma. And so I want us to make sure we keep that in mind. This is a very serious discussion. When we talk about whole government and community approach, it really warms my heart to see all of the partners here, from law enforcement, non-law enforcement, schools, mental health, economic development, hospitals, etc. You're going to hear from many of them today as we go through a few of the pillars that will be focused on mental health, violent crime, youth intervention, homeless, risk reduction. And again, I just want to say, keep this short. Think about those who we're really seeing and serve. And many of those folks don't sit in these homes with us right now. And so whatever we do here, we need to make sure we get their input and their feedback continuously, and recognize that those who are at the highest risk are often also the hardest to reach. And many of our policies, programs, and practices are not typically designed to do so. So it may take some additional flexing, some additional changes in policy, program, procedures, and staffing to meet that need. But we're going to get right into it now. first presenter is Dr. Cunning.
All right, well, I got the hard task of being right after lunch and sandwiched between all of our elected officials and community members and to talk about data. So we're going to try to keep it engaging and try to keep this in context for exactly what you heard several of our panelists talk about already, about community, about equity, about engagement. And so we thank you all for being here today and being a part of the conversation. I have an assignment for you all to do at the end, and ask of you all as we talk about data and where to get the data and making sure we hear the voices of community members. So I'm going to go ahead and get started. And as any good public health director does, you always start with a little disclaimer about the data. So we're going to not cover all the data today. We would be here for a very long time if we talked about every piece of data that impacts the health of our community, and particularly around public safety and all of these pillars. So know that we're not going to cover it all. I have 30 minutes, I think, and they're going to give me they're going to kick me off the stage after that. So we're going to kind of go through the data pretty quickly, but I want, as you all are hearing the data, the next part you're going to hear from our panelists, but I want you to be thinking about who is it that we are serving. We're going to talk about some inequities in the data and where we see some disparities. So I want you all to be thinking about what's the action item from here, right? Because the data is only good as what's the next step to reduce those disparities, where is it happening, and I want you to be thinking about the interventions and the things that will be meaningful to change those metrics in the data. We're going to talk about some of the leading causes of injury and death. We'll cover some overdose deaths. We'll talk about violence and firearm deaths and suicide deaths. And then a couple of my data disclaimers here. These are all public-facing data sets, and so this is all data that you all could go, as a community and of our elected officials, go back and look yourself. After this, if you want to kind of take a little bit of a deeper dive and to figure out where some of those disparities are happening. Some of the data is from different years, so it's not always going to have 2023 as the ending year. It might be some 2020 or 2021 data. And then, of course, I hate to bring it up in the room, but remember, some of these were COVID years, so it's going to impact the data and what we might see as some of our trends over time. And then most of this data is specifically Cumberland County data, unless I say, okay, here's some statewide data to look at as well. So we'll go ahead and get started. So first I'm going to talk about our community health assessment. So we work with our partners at the hospital every few years, every 3 to 5 years, to do what we call a community health assessment. And that community health assessment is a survey. We do focus groups. We do some key stakeholder meetings. We talk to the community to do a good community health assessment. And then the stakeholders prioritize the data into some key priority areas for the health of our community. And then we use that to make our strategic plan for the health department. We use that to plan initiatives, make asks of our elected officials. And so these things hopefully won't surprise you. These are our 2021 priorities. So we collected that data in 2020 during COVID. And these are the things that the community said were their priorities. All of these things are related to the work that we're talking about today. The economy, so housing, food insecurity, poverty, and then everything else falls beneath that, right? If we don't have a healthy place to live, to work, to food to eat, then all of those other things are impacted. So the other priorities are substance abuse, public safety, and mental health. Does that surprise anybody? Kind of rings true? Okay. So the leading cause of injury death, this is Cumberland County data going back to capturing 2016 to 2020. So, and we have some 2021 data, and the numbers are different, but the trends are the same for 2021. So the leading causes of death to the emergency department, so folks that are coming to our emergency room this is a lot of data words here, but no mechanism intent recorded. We use what we call ICD-10 codes to get this data. So they code it at the hospital as what type of visit it is. And we, for most of those visits, we actually don't know what the intent is. But I want to go to number 2, 3, 4, and 5, because that's where we're going to hang out for the next 20 minutes or so. So most of those ED visits are around unintentional falls. And we'll talk about the who is happening. Then followed by motor vehicle accidents, unspecified, unintentional, that means it didn't get specified as we coded it, and then struck by or against, oftentimes that might be something other than a motor vehicle. So let's jump here, because I think this is really a critical piece of data. The leading cause of our injuries, now if you get hospitalized, so you're out of the ED, you actually get hospitalized, are falls. We don't often talk about falling as a public safety issue, but we'll see here in a minute that most of those falls are among our older adults, but also some of our marginalized populations. So older adults, but also those numbers are higher among our American Indian Alaska Native populations. So we want to be thinking about what's going on there and what interventions might we do to help. The next one is where we're going to hang out most of the day today. So poisonings, motor vehicle, unintentional accidents, poisoning, self-inflicted, and then fire, some kind of fire or burn, something unintentional that happened here. So a lot of these things are noting here are unintentional accidents. And when we talk about overdoses, that is included in unintentional poisoning, is going to be where overdoses are going to fall in there too. So, and then if we think about what the leading causes of death are, you're starting to see a trend here, right? Poisoning, unintentional poisoning, so this mostly is our overdoses, whether it's heroin, fentanyl, other methamphetamines, motor vehicle traffic incidents, firearms, which we're going to talk about today, falls, and then firearm assault. So same kind of trends, whether it's emergency department visits, whether it is you're getting hospitalized or you are dying by these different types of method. Most of these are unintentional deaths. They're by accident of some kind. They often involve substances, and there's a lot of disparity. So let's dig in a little bit further. So the chart on the right-hand side of your screen, a lot of numbers here, but I want you to pay attention to a couple of things here. This is our alcohol-impaired deaths. So we often talk about teen drinking, right? We talk about, we have lots of different ad campaigns that are in our community and across the country around teen drinking and teen deaths due to teens. And we are definitely seeing that, but we also are seeing improving trends, aside from 2020, improving trends around alcohol use. So we are doing something right around drinking and driving in our community, and we're getting better for that metric overall, aside from we saw a big drop in 2020, probably less reporting, and then it started to go back up again. But overall, we're actually trending better for this metric. The rates of hospitalization for our motor vehicle accidents, you're going to start to see some trends here. Males, non-Hispanic African Americans, and young people, 25 to 34, and our older adults, right? Our older adults are much more likely to get into a car accident, maybe more impaired vision, motor skills aren't as strong, but we also, other than our older adults, you're going to see these trends over and over. Male, young people, and African American males in particular. So let's talk about overdoses. And I'd be remiss if I didn't mention that our county, if you're not aware, has a Cumberland Fayetteville Opioid Response Team. We call it CFORT. And that team is working to, is a multidisciplinary team that is working to do a coordinated effort in our community around our opioid response. What is the work that we're doing? And it looks much like this room, a lot fewer elected officials, but it's the people that are on the ground doing the work, so we can inform our elected officials about the strategies that we have in place to address our opioid crisis that's going on across our community. And we want to make sure that there's a strategic effort so that we can put the work in front of these folks to make some decisions about what's going on in our community. So we hear all the time that overdoses about the opioid crisis. Is that a surprise to anybody that we have an opioid crisis in our country? We hear it all the time on the news. It's big news now because we have a lot of opioid settlement dollars that are coming in both to the city and the county. But the little bit of good news is that we are seeing just a little bit of a dip in our opioid numbers. So if we look at the chart on the far left side is our 2021 data, or I'm sorry, data from 2000, and then it goes all the way to your right side. Cumberland County numbers are on top in the pink, and then state numbers are on the bottom in blue. So we are much higher than the state in Cumberland County. We have more people dying due to opioid overdoses in our county than in other places across the state. The good news is on the far right hand, you're starting to see a little bit drop back down. So we saw a big increase in 2020 during COVID. Across the country, opioid rates skyrocketed during COVID. People were indoors. We had a lot more increases in substance use, and so our numbers increased. As of 2023, we're starting to see that number come back down just a little bit, and that's much to the efforts of folks in this room that are working very hard day in and day out to address the opioid crisis. We have people that are more impacted by the opioid crisis than other groups. We often think about opioids as a disease that impacts white rural Americans, and that is largely true, right, in North Carolina and in our state. We continue to have higher numbers of overdoses among our white residents. However, in the last couple of years, we've seen a significant increase among our minority population. Those increases of opioid overdoses are increasing faster among our minority populations, particularly among our African American residents and our American Indian and Alaska Native residents than in other groups. So that's something that we want to be concerned about, and something as we think. Our ED visits are down. Year to date in 2023, this is January to March. In 2023, we had 60 opioid ED visits, and we had 51 in 24. So we're tracking a little bit better. Now, I know my folks in law enforcement and my folks at the hospital are going to tell me, everybody doesn't go to the emergency department for an overdose, right? Overdoses happen everywhere and in the community all over the place. But this is really important data, and I want to interpret that with caution. We want people to go to the emergency department, especially if they need care. So it's not always a bad thing. It could mean that we are identifying more overdoses and people are dying less. Maybe they're going to the emergency department room, but they're not dying, which is a good thing. So it's not always a bad thing to see, we have to interpret that emergency department data with a little bit of caution. All right, so what are people using when they do overdose? If we look at the sharp line at the top, I know you all probably can't read that, but does anybody want to guess what that is? If these are the different types of substances, heroin, fentanyl, methamphetamines, anyone want to take a wild guess at what the top line is? Yeah, heroin, fentanyl is that top line that's bigger or is higher than everybody else, right? That's mostly what we're seeing. It's not all heroin and fentanyl, but we're seeing a lot more of it, and those numbers are dramatically increasing much more than we've seen in past years. And look, and you can see how sharp that top line of an increase it is, right? So a lot of opioids in our community. The number that's not necessarily reflected as clearly here is the numbers around xylazine. Xylazine is an animal tranquilizer that shows up in our drug supply. And if you ask our folks with NC harm reduction and our folks that work with community paramedics, they will tell you there's a lot of xylazine in the community, right? We have a lot of xylazine that is present in the drug supply, unbeknownst to a lot of people that are utilizing those substances. All right, so let's switch gears a little bit and talk a little bit about violent death data. And this data ends in 2021, so we don't have as much recent data, county level recent data as we'd like to, but the trends are going to be fairly similar. So overall, this is our violent death data, and this is just overall violent death, so homicide, suicide, all of those different metrics are included in this number here. It starts on your left-hand side in 2024, and then goes all the way up to, we don't quite have 2022 data yet, so it goes all the way to 2021. And you can see that those numbers are increasing. Again, we have populations in our community that are much more likely to be impacted. If you are male, if you are African American, if you are American Indian and Alaska Native, those numbers of violent deaths are higher for you. And our transitional age youth, so our 20 to 24-year-olds, so our young people, are those that are much more likely to be impacted by those violent death numbers. So this chart looks at our violent death data. We're breaking down homicide and suicides. So this is a little bit interesting because these numbers have flipped. If we had all the time in the world and we went year by year, these numbers would flip back and forth in terms of the greatest percentage of our violent death. So this is 2021 data. Homicides 40%. And suicides about 55% of our violent death. You're going to see that number flip a little bit when we talk specifically about firearm data. So keep this slide in mind just for a minute. So we have to be thinking about, it's not all homicides, it's not all suicides. We have to be thinking strategically about homicides and suicides. And I think the folks on this panel would tell you part of that, a big piece of that, and the data shows this, is about our firearm violence and what we can do from a public health perspective to address that. All right, so this data is just quickly doing a little deeper dive into our suicide trends. Again, you got 2024 data all the way on your left side. You got 2021 data all the way on your right side. Those numbers are a little bit leveling out. That dip on the right-hand side is 2020. So we saw a decrease, probably less reporting, and then those numbers jumped right back up. Again, highest rates among males are young adults, 20 to 34, and our older adults. I'll say by rate, our older adults have a high rate, but that's because there's fewer of them, right? So we have to interpret that with caution. We've got a lot fewer older adults. The number is small, but the rate is high. And then higher among our American Indian, Alaska Native populations, and then our white individuals have higher numbers, but the rate is much lower, right? There's more white individuals in our community than any individual minority group. All right, so this slide's a little messy, but I'm going to tell you what it means. So on the left-hand side of the slide, you've got statewide data, and it's telling you the percentage of our suicide deaths. So take all the suicides that happen across the state. Most of them are the method utilized is a firearm. Is that surprising to anybody? Kind of, it rings true, right? So firearms, it's in the numbers, so 59, almost 60% of our suicides in our state are by firearm. If we look at the data, the pink and the blue bar is by gender. So women are much less likely to use a firearm than men are, and women are more likely to utilize the method poisoning, or a different method. So, but again, that tracks, right, with the data that we just looked at. We said firearm deaths are highest among males, that this tracks with that. So switch to the right-hand side of the screen for me. That top bar is still firearms. So these are suicide deaths in Cumberland County by method. And about 60% of the firearms of the suicide deaths are by firearm. Yes. Yeah, I'm sorry, because they're going to kick me off the stage. So we have about a quarter. Yes. Yes. Okay, so real quick, yes. So about 25% of the deaths in our state are by hanging, and the numbers are about, if you break that 25% down, male and female, they're about even for hanging. But where I really want to hang out is the firearm, because that's where we see the majority of our suicide. And the same thing is true in Cumberland County. We don't have that broken down by gender specifically for Cumberland, because those numbers get real small, and then we run into some data issues with privacy. So, but about 60% of the suicides in Cumberland are by the method utilized is a firearm. So let's switch to homicides. We talked about suicide a little bit. We see the populations where the rates are highest. So let's switch to suicide. The trend is similar. We are seeing an increase in our homicide rates. Again, this data ends in 2021. I'm sure our folks with the police department can talk more about our more recent trends. But the homicide rates are the highest among our males, our young people, and our African American males, 15 to 34. And then, so here's this number again. About 80% of our homicide deaths are by a firearm. So if we think about impacting both suicide and impacting our homicide rates, we have to be thinking about firearms. And this is new for us in public health because for a long time, public health has kind of stayed out of the conversation around firearms, because we said that's behavioral health, or that's mental health, or that's a crime issue. But we know, as you heard Dr. Tate say at the beginning, this is a public health issue, and so we want to be talking about that as well. Yes. Okay, so we're at the end. So I'm going to go through this very quickly. So our firearm by emergency department visits, we're going to see the same trends. Young people, these are emergency ED visits because of a firearm. Young people, 18 to 40. Male, these are firearm emergency department visits. By race, African Americans, that third bar, much higher than everybody else's. And then our emergency department visits among Hispanic versus non-Hispanic, much higher among our folks that identify as non-Hispanic. And then if we look at our data for firearm deaths overall, highest again among males. Those numbers are increasing dramatically, highest among males, African Americans, and our young adults. And again, I said, remember this chart, about 55% of our firearm deaths are by homicide. So how do we put that back together? And then I'm going to give you all one piece of homework before I get off the stage. So substance use, mental health, and firearms are a big concern to public health. All these things link together. We have to be thinking about the interventions that we want to talk about around gun violence. The overdose emergency department visits, we've got a lot of really great things happening in our community around overdoses, and fentanyl is a big contributor to that. Our firearm emergency department visits have decreased just a little bit, but the death rate has increased. And then again, we have, as Dr. Tate said at the beginning, we need to be thinking about the populations that are the most impacted. So our males, our young adults, We have higher rates among our African Americans, and then for some metrics, our American Indian and Alaska Native populations, we're seeing much higher rates. So those are the things that as you all go through today, I want you all to be thinking about, how do we have an impact in that number? How do we change those metrics in public health? And then my last homework for you all, if you all can take out your phones. I mentioned our community health assessment was conducted, we collected the data in 2020, which means it's time for us to do it again. If you all will do your QR code and share this with other people, we are collecting the data. This is a collaboration between the health department and the hospital. We utilize this data again to set the trends for our community. We need you all to take the survey. It closes June the 7th, and this data helps us to inform the work that's going on in our community. So please take the survey, share it with your friend, send it to a friend. And we really appreciate it. I'm looking forward to the conversation today.
Thank you very, very much to Dr. Green. We often say that we want to take a data-informed approach. Well, you saw a lot of data, right? You saw a lot of data about what's happening, who it's happening with, who are those highest risk population that are most disproportionately affected by a number of different harms and injuries. So I'm going to ask, I'll try to be a little interactive because I'm a social worker. Somebody give me, what trend did you see of the highest risk population? Let's go age first. Anybody, raise your hand. What age did you see continue to come up? Yes. 20 to 34. Okay, now what gender? Male. So we got male, 20 to 34, right? And what race? So we're all on the same accord when we looked at the data about highest risk, disproportionately impacted population, right? So when we start talking about take a data-informed approach, and I started and level set it by, let's look at the data about who's being most disproportionately impacted around which harms, we all got to understand what the data tells us now, right? So when we start thinking about interventions and shared risk and protective factors for that population, we have to dig into what are some of the risk factors that are associated with that particular population that makes them at a disproportionately higher rate likelihood to be injured. So I will ask some of our panelists here, what are some of those risk factors from that population that you see in the work that you do? City. Unemployment being one. Would everybody agree that unemployment amongst that population is a big issue? Poverty, unemployment, housing, right? So these are the root causes of what gets them to the hospital. So when we start talking about developing interventions on the prevention side, we should hear conversation about, what did we just say? Poverty, employment, housing, education. The mental health crisis piece is because I got to deal with all of those stressors in my each and everyday life, right? So a lot of times we look at it at the end, right? This is what's happening. But I see opioid overdoses, I see motor vehicle accidents and drinking. What are some of the ways humans in general cope with a lot of stress and trauma? Substance abuse, alcohol, there's a correlation. Violence, absolutely. I grew up on the south side of Chicago. Being hypervigilant while I grew up in Inglewood was normal. I'm a therapist. If you were not hypervigilant where I'm from, with the amount of bullets and violence that was happening, there was probably something wrong. And so, again, when we think about data-informed approach, it sounds nice in the books. It sounds nice on the paper. It sounds nice as a talking point. But now we have the data that shows us what's happening and who it's happening to. So when we start talking about policies, programs, procedures, outreach and engagement, let's have a specific focus on that population, right? And it was a little bit older in some cases, American, Indian, Native Americans and others. So when we start to talk about those things, let's look at it. But the shared risk factors and shared protective factors, and what I mean by that is there are certain things that make you at higher risk for becoming victims of violence and crime or participating in it. And we just talked about a lot of that. So if we only speak about CVI, community violence intervention, or we only speak about law enforcement approaches. Very few, if any of those, address housing, employment, mental health care, primary health care, any of those things. So in this, we want to broaden that conversation. We're going to talk a little bit more with a couple of our panelists around mental health thing, homelessness. I often tell police and CVI folk, most of the individuals, the young black males that we work with, are not on their own lease. What do I mean when I say that? Somebody. They living with somebody else. Sometimes that's couch surfing. Anybody heard of Maslow hierarchy of needs? Well, if I don't have a safe place to live, you asking me to do very complex things with my life when I'm couch surfing and the basic fundamentals are not being met. So those are things we want to dig into and talk about a little bit more here. I'm going to sit down now and get ready to move on to our next panelist. Yes, sir.
Yes, sir. The next panelist will be mental health. So, Ms. Carroll.
My name is Janet Carroll, and I'm the 30th president of MOM, which stands for the National Month of Mental Illness of Common. NAMI is a grassroots self-help organization. It was born at the table of two mothers who had adult sons with schizophrenia in 1977 and became and then NAMI in 1979. What is NAMI? NAMI is dedicated to the improvement of the quality of life for everyone with mental health challenges and their loved ones also. Because when the first train of mental illness comes, it does not go it not should go down. It doesn't just affect the subject with the mental health challenges, it affects the whole family. So what is NAMI? NAMI educates, supports, and advocates, and also resources to them. We offer a array of classes, presentations, and support groups. And all of our services are free to the public. NAMI has classes for family members because when your loved one is diagnosed with a mental health disease, sometimes it looks like Saturday, but that's the only similarity that you have of Saturday. It's not the Saturday you worked with for all of those years. So I'm a stranger sitting at your dinner table. So you have to learn how to deal with this new illness, this new person that's there. Sometimes it's not what you say, it's not even how you say it. It is how it is perceived. So NAMI works closely in our classes with family members, teaching them the I statement, teaching them reflection, teaching them how to communicate with their loved ones. We have the people, our support groups, they're not come and write sessions. They are work sessions. They are sessions where you may come in, but be sure you don't want you to leave. They're the worst thing you did when you came. And that's what happens when you just come to write. Yes, we did. But then as a group, we have an agenda and we work through the issues that are presented in that support group. Okay, the students asked me to tell what those offer, the classes that we offer, how they are affecting people, and how people come in feeling all alone, and then they leave feeling so much better. But where could we be doing better? Where? And one thing is that I see that NAMI is one of the best kept secrets in Cumberland County. If I was to ask how many of you before you came into this room was really familiar with NAMI, I'm sure the number would not be in a big proportion. So that's something that I feel that NAMI really needs to work with. And it needs to work with connecting. Because we don't need to reinvent the wheel. There are other people in Cumberland County that is doing things with mental health. So we need to come together, connect, and offer services to those who need services. A lot of times we look at just the person with the illness, but now started because of the mothers. And so when you're working with people with mental health challenges, remember, family is important to their survival. Family is important. A good support group can make a good improvement in anyone's life with mental health challenges.
Thank you so much to NAMI. And we want to make sure that we're sharing information. There are a number of great organizations in this community that do mental health services, and we want to make sure that all feel that we are promoting and supporting all of your services, because it will take a village to solve this. I wanted to leave a few minutes for Dr. Tate to now kind of talk a little bit more into that. We are kind of being very strict on the time with the agenda, because at the end of it, I would like to hear from you guys. There's a process that we have set up to where you are given a card to write your questions that you would like mentioned. We're going to try to get to as many. If you don't have a card, Ms. Jody Phillips, the Assistant City Manager, is in the back. She has the cards. Make sure that we hear from you, because it's about the dialogue. But with that, I'll pass it on to Dr. Tate before we move to the next item.
Thank you, Mr. Mayor, and thank you very much. When we think about behavioral health, one of the things that I think when I first started school for social work, I had a professor tell me behavioral health is health, Gerard. And I didn't know what it meant when she said that to me. But if I used to play basketball a lot, and if I twist my ankle, sometimes it swells, I need to treat it, right? Sometimes I can get back to normal. If I break my ankle, sometimes it's hard for it to ever get back fully 100%, but I can get back more functional, right? The reason that I say that is because if behavioral health is health, we all are going to go through ups and downs sometimes, right? And so a lot of times what I see in an intersection with that and violence is we see sometimes normal reactions to crises and mental health crises that we sometimes ignore that then go on and get worse later on, right? And so when you see whether it's loved ones you have, people out in the community, people that you're working with, particularly the population that we talked about, oftentimes are least likely to seek mental health support, not because they don't think it's important. It was not designed typically for them historically, right? And so as we start to expand around what behavioral health and mental health supports look like for highest risk populations, just be cognizant of oftentimes it doesn't always look like the crisis we see on TV, right? Sometimes it is that person sitting across from you that may be acting a little bit down for a long period of time. They may be reacting to a loss in a very normal way, but we have learned, especially in certain cultures, that crying or sometimes dealing with emotions, normal emotions, is something that you should not do. And so creating safe spaces for young people and older people who may be experiencing mental health crises is vitally important. I will say this, I typically only like to add this when it's beneficial to this crowd. I think it will be. I was retired from the Army for a mental health, a serious mental health issue. And you see me up here today, right? and I'm continuously in therapy and those things. So you can recover and do well. I'm particularly saying this to my males in the room, who are often least likely to seek support, but as I see the numbers, are most likely, when they don't seek those services and supports, to end up with serious mental health issues. I also want to highlight one thing. We have behavioral health community paramedics. Are they in the room? Yes, you are in the room. And can you raise your hand? All right, so we won't do it now, but when we get to questions later on, they are here. They deal with it on the front lines each and every day as well. And so you want to make sure, if you have any questions, know your ecosystem, right? When I mentioned ecosystem before, oftentimes we have all of the resources we need, not a lot of the coordination. Or the mayor and team and the council and city management team want to make sure that we wrap around that coordination piece. All of these people offer services and supports, but how do we get it to the population who need it the most? Last thing I'll say about behavioral health, to make you remember, behavioral health is health. You go see a doctor, or supposedly every year, biannually. We get teeth cleanings often, right? How often do you do mental health checks? When the last time you did yours? When the last time you did a self-assessment? If you have children, if you work a stressful job, failure to do that, failure to take care of your physical health can affect your family, right? It may lead to greater issues later on, preventable diseases from occurring that may shorten our life. Mental health, the same thing. Mental health is health. Okay, so moving on to our next speaker, we have Captain Jones. Yeah.
Hey everybody, I'm Captain Jones. I'm the Assistant Chief of Detectives for the Cumberland County Sheriff's Office. I've been working with the county for about 19 years, pretty heavily involved in the violent crime field. I was in major crimes from about 2009 to 2021, and that's predominantly what we handled. It was just violent crime against the person. I helped stand up the first human trafficking task force in the area back in 2013, so I'm pretty proud of that. We're still heavily involved with that, and that is an aspect of violent crime as well. I'll give you guys some stats, just some overviews for the county in terms of violent crime. From 2022 to 2023, violent crime was actually down approximately 9% in the county. However, murder was up from 16 to 21 during that time frame. Ag assaults were down 11%. And however, our sexual assaults actually went up approximately 5% during that same time frame. Those numbers tend to ebb and flow. It's just like anything else. So from time to time, you'll see some increases or some dips. To kind of go along with the gun violence that we were talking about earlier, there was actually an 18% decrease over that last year in ag assaults that were directly related to firearms. Some things that we've been doing well in the county, we have used our resources really well. As many agencies and departments within the county know, we have a staffing shortage. We work quite well with the surrounding law enforcement agencies, Fayetteville PD, Hope Mills. We do as much as we possibly can to combine resources and put everything in one pool to try to kind of pull together and investigate these cases as much as we possibly can to bring the families justice. We do a good job of working with community partners, places like Crime Stoppers, the Phoenix Center, the LEAD program, C-Fort, heavily involved in the schools with the SROs and trying to reach out to youth. We also use technology way more efficiently than what we did when I first got into law enforcement. We tend to be able to link cases quite efficiently, and that allows us to investigate cases that maybe go across jurisdictional lines. However, as we all know, there are some gaps and there's some things that we can improve upon. We need to get better at the intervention and education side. Law enforcement can only do so much in that front. If you think about it, we do things like Operation Ceasefire. Fayetteville has the PAL League. National Night Out's a big thing, and of course, Great Camp and things of that nature, where the SROs are right there on the forefront with the youth. But law enforcement can only do so much, and so we have to do a better job of reaching out and kind of looking at a holistic approach to how we can kind of intervene on this. Another thing that we could do better is just continued and updated training for us. We're just like anybody else. If we aren't keeping up with the current trends and trying to get ahead of them, then we're falling behind. And I think that's about it for us.
Thank you so much, Chief. We did, if you would briefly speak, we do want to give some time on this topic to the Chief Justice of District Court, Judge King, as well as Chief Braden. But if you'd like to take a moment, did you have something you wanted to add? No, so they have the mic. So I'll go to Chief Judge, District Court Judge King.
Thank you, sir. Again, my name is Tony King. I am the Chief District Court Judge here, and I do this conference Judge Sheriff and Judge Keegan with them who are in this room as well. Speaking of the juvenile aspect, since you got these numbers from the adult aspect, on juvenile, and we are not seeing a drastic increase in the number of juveniles that are getting in trouble. I sat down with our Chief Court Counselor, Jason Hunter, about a couple months ago to compare some of the numbers. And with regard to the numbers of youth, there's really not a big shift. The issue is youth are committing more violent crimes. And so that is the issue that we are facing here in Cumberland County. And you've heard there are a lot of community resources, but certainly we need people that are willing to volunteer to be a partner in those resources. And so from the court perspective, even though we could typically just say we're judging and we're going to go on the bench, we have an active bench here in Cumberland County. And so we have developed a mentoring group where judges meet with these youth every third Monday at community. And we have activities and events planned for them. And that was something that we partnered with the city with. They help fund that program. And we meet with these kids. But one of the things that we found out is that we children need mentors, but their parents need mentors. And so we bring all of the families there. We have dinner with them. We play games. We have activities. One thing that stands out to me is we took the whole families, all the families, out to bowling. We had a family that never been bowling. And it was something like that little thing that connected that family. And so, as we talk about a holistic approach, we need to look at not just the juvenile, but what's going on with their parents. Another thing that we did is we sat down by partners at Fayetteville Technical Community College. They have what they call a HOPE program. So we're starting to implement that in our court system. So they're going to get trained in about 18 different disciplines: welding, electrician, HVAC. And what I asked Commissioner Adams and Commissioner Keith is, can we have an individual come sit in our courtroom? And so now when they say, just from that, just King, I want a job. We get you some training. It's a 12-week program, and they're going to get certified in all those areas that makes them employable. The other thing that we do is we partner with NC Works. They have a teen youth work program. We recommend that our juveniles go there, get in their database, and start working. We get people that come in our court and say, Judge, I can't get hired, but I'm going to be a good felon. We developed a list of entities in our community that hire convicted felons, but also NC Works has a program. Doesn't matter, they'll get you employed. And so what we found is that we can tell people, go here and do this, but really people need a hand to hold so that you can guide them. And so bringing them in our courtroom and having that person to the left that says, oh, we'll come over here, we'll help you fill out the application. That is what's helping us, and that's what the court system is doing in efforts to try to help our community partners combat the problems that we see.
Thank you, Judge King. Also, before Chief Braden speaks, I want to acknowledge Judge Cole Jordan. I think he tipped in back there. Good to see you, Judge. And you caught Judge Whitfield sneaking in the door back there. But welcome, judges. Chief.
So, as a positive note, as I did the annual report for 2023 presented at the council, we noted a 7-year decrease in crime in both property and violent crime categories for the city of Fayetteville. I think that's a positive aspect that we have to really focus on and see what has been successful for us over the past 7 years. As I look at programs that have been a part of the Fayetteville Police Department in addition to what the county has spoke about earlier. You know, we took a long look at many of the things that were talked about earlier, you know, the things that affect the health of our community. We know that the incident at Applewhite actually talked about it prior to this meeting here this morning, about poverty, about addiction, about mental health issues. You know, through the city, we have our Faith in Action program, which started as an overdose response, where we picked the 3 highest locations for overdoses within the city and worked with our LEAD program to go out and supply Narcan to those areas. As we were out there with that mission of cooperating with LEAD, we saw that there were all these other problems that arose. We had the food insecurities. As we continued late into the fall last year, the weather began to turn cold, we saw that there weren't some coats or clothing for the winter for these individuals. So, you know, we've adapted that program to meet those basic needs. I think that's what Dr. Tate was really trying to emphasize on earlier, in order to alleviate some of the problems that we see within those areas. But we know that from the police department aspect, that is just a small portion of our community that we're affecting at any given time. We know that, okay, we may be there handing out Narcan today and out responding to a violent incident that night. And it's going to take more than just the police department in that area providing those basic needs to those individuals to have true and impactful change for those areas.
Thank you so much, Chief. With that, I'll give it back to Dr. Tate. I think there were a few more on this as we move to the next pillar. And Dr. Tate will explain the significance of the pillars as well as the data that we have compiled so that as the city works with you to build out this new Office of Community Safety, we're in the hands of good professionals that are pointing us in the right direction. Dr. Tate.
Thank you, Mr. Mayor. We'd love to hear from North Carolinians against gun violence now, please.
Thank you so much for having us here today. My name again is Becky Kirchdas. I'm the Executive Director of North Carolinians Against Gun Violence. We've been working for over 30 years to prevent gun violence throughout our state. One key component that we've seen in other offices is that the Office of Community Safety can support community violence intervention programs. These programs take a public health approach and are evidence-based to reducing violence in our communities. Street outreach programs employ violence interrupters that directly mediate conflicts before they turn deadly. And outreach workers try and get at some of those root causes of gun violence that we spoke about before. It's really important that these workers are from the communities that they serve and have existing relationships. Another type of community violence intervention programs are hospital-based violence intervention programs. These directly engage patients while they're in the hospital to see what they need to prevent retaliation and re-injury. There's been a growing body of evidence that show that CVI programs work and have been proven to save lives. For example, Safer Streets Baltimore found in 5 of their target areas that there was homicides were about 23% less likely to occur over the first 4 years of that program implementation. Here in North Carolina, Greensboro's CVI program, the Gate City Coalition, saw that in the first 6 months of 2023, there were 0 homicides in their target area. So these are very exciting and very promising programs. We currently have 5 cure violence-based street outreach programs in North Carolina and 6 hospital-based violence intervention programs. Again, we recommend that an Office of Community Safety actively supports community violence intervention programs. And I'll now turn it over to my colleague Brent Bailey to talk briefly about funding sources, technical assistance providers, and an example of Office of Community Safety.
Thank you, Becky. As she said, my name is Brent Bailey. I am representing Community Justice Against Gun Violence. So just a little bit more on that funding component around the work that we felt active for on federal, state, and local levels. So the President's American Rescue Plan has helped states in over 1,000 cities, towns, and counties invest over $15 billion in public safety and violence prevention. And there is $90 billion available through the Department of Justice's CDI and PI grant. This also includes $1.5 billion in mandatory funding to support this CDI programs over the next 10 years. And so this administration has created the first ever federal funding stream dedicated to CDI, the Community-Based Violence Prevention and Prevention Initiative. And so While we talked a little bit about funding, I can tell you also about these technical assistance partners who are helping a lot of this work expand across the country. So just to name a few, there is Cities United, HAVI, Community-Based Public Safety Collective, and the National Institute for Criminal Justice Reform. All of these organizations focus on different areas around violence prevention, but also helping offices of violence prevention, offices of community safety, and also CBI-led work to expand in whatever capacity it needs to be. And so lastly, just to kind of encapsulate it all, there is a local program in North Carolina that we'd like to highlight, the Mecklenburg County Public Health Office of Violence Prevention, located in Charlotte. And so this Office of Violence Prevention is responsible for identifying community partners, securing support and participation from those community partners, collecting and analyzing data, and then also developing and sharing those periodic progress reports to the community, to stakeholders, and different folks who may want to learn what's the progress on these investments. And so just to acknowledge some of those accomplishments that they've achieved since then, the way forward is a comprehensive 5-year strategic plan that they did for violence prevention for the county. In this way, that as we continue talking about what we can do here in Fayetteville, how can we create this comprehensive strategy where it's all hands on deck. And so they created a way forward. I encourage anyone who is interested to check it out. And I believe we have some copies available for you all as well. And then also, what we see very commonly happening is the Peacekeepers Academy, which is something where we have these offices, the community safety offices, violence prevention, invest in local community organizations to also expand this work on the front lines. And then lastly, a Cure Violence program, Alternatives to Violence, has also been started in Charlotte, and they assist and work hand in hand with that Office of Violence Prevention. And so that's just a local example, some funding available, and also who are those technical assistance partners at the state and federal levels. So the last thing I'll say is, in these spaces, as Director Tate was talking about, how often are we including and making sure that young black men and adults are also in these spaces, right? And I'm sure we can count on a handful of how many of them are in this room right now. So as someone who is a black male and 26 years old, I often say that we're not always going to be packaged in a suit and presenting, but I encourage everyone in their capacities to please make sure that you're tapping into whatever ways you can to touch us, reach us, and make sure that we're at these presentations and in these rooms. So thank you.
Thank you very, very much. And you are definitely on your way to becoming an executive director at a state office one day soon. And you know I'm here to help that. So we're going to go to Ms. Gaines from JCPC around kind of that same tone around particularly young people and violence. Ms. Gaines.
Thank you. My name is Michelle Gaines, and I'm the current coordinator for our Juvenile Crime Prevention Council. I'm also here with our chair of the council, Mr. Mike Fiala. So the Juvenile Crime Prevention Council is a partnership with the Department of Public Safety and the Office of Juvenile Delinquency. And the purpose of having the Crime Prevention Council here in Cumberland County is to create prevention programs as well as early intervention programs, and to service those that are already justice-involved youth. So within our council, we have an array of community members that are on our council. So examples, we have law enforcement, our faith community, local government, mental health in our school system, and so much more. Our JCPC, they study the risk factors and the needs of the youth in our area, and determine of where those gaps of services are. So the JCPC receives funding from the Department of Public Safety, and once a year we put out a request for proposal for those needs that we see are needed here in the county. And we fund several programs here in this county for prevention, intervention, and justice-involved youth. One of the big things I can say about Cumberland County and our JCPC as a whole, there are a lot of resources that are available in this county for our youth. I believe that we're above the curve from a lot of other counties and other states that I've had the privilege to speak to, that we offer a whole lot more than what other people have available. It's just making sure that our community is aware of what is available for them, that outreach that was talked about a lot, the collaboration, and that is something that our JCPC is currently working on, is that public awareness piece to make sure that those in the community are aware of the resources that are available to them, and how that they can get in contact with these communities' resources. I'll turn it over to our chair if he has anything that he needs to add.
I will also tell everybody that I'm very proud to be chairman of our JCPC. I think we do work very, very hard. We spend a lot of time looking at ways to improve the juvenile. Obviously, that's our purpose. Kind of going back to what Dr. Kay said, just to start off, and kind of, it's for me a little more difficult math to go after everybody else who said everything, but I will tell everybody that everything that I'm hearing here is very accurate. The same things that we've been looking at. Dr. Kay said, we have all the resources, but we don't have that coordination. And I will add to that, sometimes we don't have participation of parents, sort of what Judge King was talking about. And we have all the resources, and again, I'm not going to steal it, I don't know if he's here, but Mr. Hunter, he's not here, but he's correct. I've had conversations with him, and it's not for lack of resource that we run into any issues. It's getting the kids there and things like that. I personally think that going into this program, we've obviously pointed out gun violence. We've talked about the poverty, lack of education, or there's no guidance whatsoever for these youth. And I think that it runs its course. I've had a pleasure of practice in juvenile court with Judge Cameron, Judge Whitfield, Judge Solomon, and Judge Jordan back there. In these courtrooms, and I've had the pleasure of actually talking to these kids where they can kind of tell me a little bit more than I think they're allowed to tell other people. So I've had that opportunity, and I really enjoyed that, being able to use that and implement it in our JCPC program. So I'm very privileged to be on it. I know that there's issues that we continue to try to remedy and try to help with. And again, I think, as Mr. Hunter said, it's not for lack of resources. I think the county does a great job providing these things for these juveniles. It's just coordination and participation.
Sorry, I'm battling some allergies here. Who here does not know what JCPC means? So everybody knows? Okay. Can we tell them what JCPC is?
The JCPC is the Juvenile Crime Prevention Council.
And what do you do? I just want to make sure that everybody's levels, because you do amazing work. I just want to make sure everybody knows. A lot of times we use acronyms. I'm to blame, just so they know.
Okay, I'll go back. So the Juvenile Crime Prevention Council is a partnership with the Department of Public Safety and the Office of Juvenile Delinquency, where the council searches and studies the risk factors and the needs of the youth within our community. And we work together with the state with funds that are received to then fund programming in our county that can address those needs.
Thank you so much. So they do amazing work. And I started this by level setting it intentionally about data-informed approaches and identifying the highest risk populations. We hear about a number of resources. You hear from different entities that we have the resources. How do we get the young people and young adults there to actually receive those services and supports? I will say that it's often not hard. Sometimes it takes time for me to get law enforcement partners to say that they'll make those diversions or that they will refer people to services and supports. Not because they don't want to. It's been my experience that oftentimes they will make those referrals, and then the follow through, the ecosystem to support the people that they're referring is not there, and then guess who has to respond again the next day? And so if we want to truly develop a balanced ecosystem, we need to invest much, much more in that ecosystem that is designed to support who the courts and law enforcement refer. And even before that, and I'm sure Chief will tell you, and I don't want to speak for, we oftentimes will go to, and I say we, it used to be my old career, to the same homes over and over and over again before an arrest is made. We need to have somebody prior, and non-law enforcement as well, right, and CVI, if CVI refers people to services and supports from the county through the city, there has to be a partnership, right? And so when we look at city, county, and state partnerships, any Office of Community Safety should be co-house those resources, right? Because when you're talking about the individuals who are the hardest to reach, they don't have time to go through the normal in processing and intake procedures. Somebody tell me what they think happened if Chief identify a high-risk youth who may be involved in crew or gang violence, who may be in fear for their life. They make a referral for safety and support through Health and Human Services, and they don't get to them for 4 days. Somebody tell me what you think gonna happen. They have a high likelihood of what? Dying or injuring somebody else. But we know who they are. Again, it's been my experience. We have the data about down to zip codes, down to literally housing areas, down to blocks where most gunfire is happening. There are individuals on those blocks, in those housing areas, who need a lot of our help and support, and not just one time. So you get a call and you get an alternative response, which I'm also a proponent for. But that alternative response gets to that house, maybe reduces whatever crisis is happening then, and then they go to the next crisis. Guess who got to come back when the next crises pop up? And guess who can't take 4 or 5 days to respond to that referral? And so when I made my transition from law enforcement to the public health side, one of the things that frustrate me the most is how much time, and it's not because of lack of effort on the individuals in Health and Human Services and public health. Dr. Green, I think you mentioned, we haven't spent a lot of time on the public health side delving into gun violence. Some of that was because there was a lack of funding intentionally at the national level, which is a whole nother conversation, right? We couldn't even get the data and information about what was happening. And so we have to build a robust wraparound ecosystem to support the young people that we're talking about. And again, it's not 1 week. They didn't get into this problem in 1 week. When we look at those ages, I want you to think about how much trauma and violence and surviving on their own they had to do for the last 17 years. When you see many of these young men that are way more mature than they need to be, that's because they've been feeding their family since they was 12. They've been taking care of their little brother since then. I was 12 years old taking third graders to school. I shouldn't have to do that, but I also grew up in a crack epidemic, which also affected here. And so many of the parents of these children, guess what, are my age, who grew up with that too. So when we say we want more parent accountability, also remember how much trauma the parents then been through. Do they know how to navigate the system? Did they have a fair chance? The answer is no. And so we do a lot of blaming. We have to do much more support and wrap around, we mentioned it here, whole family support. And typically the individuals that we're talking about, the families that we're talking about, are often the ones who we just kind of walk past or walk away from or are afraid of. Right? And so, again, I try to keep it as balanced as possible. I can get law enforcement typically to make referrals and do things different. Social services, public health, community-based organizations have been doing it without a lot of funding. They're often based in those neighborhoods without the capacity building, the training and support. The city, the county, and the state has to come together to support all of these entities. It's a safer environment, and everybody has a win, right? If we improve public safety in the city of Fayetteville, who's safer in this room? Everybody. You making extra investments in time, even if it's selfish, even if you never go to that side of the town, you ensuring that those kids get services and support, meaning that there's less likely to be in crises, kicking in your door or taking your weapon out your car. So if we don't see that as a whole community and we stay divided, then when those young people who we know where they are, who they are, where they live, what they need, start to do things that unfortunately are natural in crises, then we all have to look at each other. So when we talk about Office of Community Safety, Talk about all of these resources that are out there, but a lack of coordination. A key thing is to use the data that is showing that the majority of not only our calls and hospitalization and other thing around violence and gun violence is with which population, what age? 17, 24, all the way up to 34. What gender? And what race? Anybody mistaken on that? Now, who's often the least to go to these programs and services that we're talking about? We all on the same page now. How do we get those young men to get to the services and supports we know they need to not only keep them safe, but who else? All of us. And our failure to do that effectively means all of us are at greater risk. That's why we're here. Now, historically, nationally, state-wise, locally, we haven't invested in that population. And we lean very, very heavily on the police to continue to go in there. You know what they won't tell you? How much time they dig in their pocket and pay for them to get food when they go into the house with a call for a domestic violence. And the refrigerator don't work. And the kid going for shoplifting and having a mental health crisis. They tell you what it smelled like in that house? Ask EMS. So are we going to come together? Also, community say it's supposed to be the coordinating body. But the city and the county and the community are not all working together and developing policy programs and procedures to serve that population first and foremost and intentionally, then we're going to be up here just talking back and forth again and wondering why. But we know. So whatever we continue to talk about, let's make sure we all on the same accord, who we going to serve, what those gaps are, and that may mean you got to spend some more money. That may mean you got to hire some different people. Because they have a lack of trust in government. Why? Somebody tell me why. Why they think? Anybody? Because we've been arresting them and from school to prison pipeline to infant mortality rates. Somebody tell me the race of women that have some of the highest maternal and infant mortality rates. So we all know that. So before they're even born. So we all on the same page now. So anything we do, we say if we don't want to invest in it, if we don't want to focus on that population, just say that. We've been doing it through actions nationally anyway. But if you really want to do something different, that's why I'm here to try to help. If we really want to do something different, then we have to all do it. That means if you have a business, if you have a church, if you have a community program, start collecting data on is that population getting to you. If you say you have food, services, and support, then let's get it to them. Let's be intentional about using the data to do outreach and engagement where we need to see it. When we look at reentry services and homelessness, they come to the top too. We see them hanging out on the corner and hanging out at the gas station. We just talked about most of them not on their own lease, right? Most of them living with people in subsidized housing where they ain't even supposed to be there. But where else they got to go? I worked with a city who said we need to move them all out of there. I said, move them where? Where you going to move them? Where they going to go? You definitely not going to develop no housing for them. I'm a realist. So wraparound services and supports for the whole family. So we're about to go into homelessness a little bit, but I wanted to make sure that this crime and violence piece did not have just a crime and violence narrative. It's a social determinant, it's a health issue. It's a, what we say, what are some of the key root causes? Lack of what? Poverty, unemployment, lack of education. Now, what programs we need to develop specifically for them? Those things. And if you don't do it, or if you say we don't have political will, we don't have finances, we don't have a whatever, what's going to happen? And there's two groups of people in here who cannot say no. Somebody tell me who they are. Well, I can give you a guess right now. Fire, EMS, and the police. And I'm telling you right now, they're not going to tell you they're tired of responding to social determinants of health issues that need to be addressed by whole of government and community. You look at their calls for service, it will tell you. They often risking their lives each and every time they go in those neighborhoods because most of them are violent and hypervigilant due to social economic issues. So, I know I talk real loud. That wasn't my, if we here, let's do it right. We got one more speaker, and then we're going straight to questions. So we have Ms. Newton and Ms. Brown, Community Development and Continuum of Care.
Good afternoon, everybody. My name is Devin Newton. I am the Community Services Manager at Cumberland County Community Development. We administer federal grants for the Department of Housing and Urban Development. Some of the grants are entitlement grants that we use for affordable housing construction and rehabilitation. We provide public services for low to moderate income people. We also provide homeless services through the public services agencies. And then we also do community development and economic development projects. So as part of our duties, we also administer what are known as competitive grants. And as the lead agency for the Fayetteville-Cumberland County Continuum of Care, that means that we apply for program grants from the Continuum of Care program as well as the Emergency Solutions Grant each year. And the Continuum of Care grant is about $900,000 each year. The Emergency Solutions Grant is about $135,000 each year. And our nonprofits apply for projects. They apply for projects and sign contracts directly with housing and urban development. So I've been with the county for about 10 years, and I've been in this department for about 5 years. And part of the Continuum of Care is we are a network of nonprofits. Some of the agencies that are here on this panel, in this room, healthcare providers, employment, job trainers, our reentry council, activists, other government agencies, and what we do is we try to work together to improve system delivery and customer service for our homeless population. All right, so some of the things that we have learned in the last few years is, well, you don't really have to do a study to know that we don't have enough shelter beds here in this community, right? The only shelters that we have here are the Salvation Army and the Dream Center down on Person Street. And the county did a 3-year affordable housing strategy plan back in 2021, and as part of that gaps analysis, they identified that we were extremely short of shelter beds, which we all already knew, right? So we have made progress. The county is, of course, constructing a homeless support center, which should be complete in the next 2 years. So we are making progress on addressing the shelter bed issue. So another gap that we have in the community is affordable housing, right? So homelessness is a housing problem, right? Because you can have substance abuse issues, you can have mental health issues, you can have criminal records, but those are just barriers, because if you have enough housing, you will have places for people with those barriers to go. So the city of Fayetteville, back in 2021, they did a housing study, and they identified that our community is about 20,000 beds or units short of affordable housing. So we're missing 20,000 affordable housing units. So when you look at the population of our community, we have about 50% of our community are renters, and about 50% of those are rent burdened. And I don't know if everyone knows what rent burden means, but that means that you are paying more than 30% of your income towards your housing costs. So 50% of our renters are cost burdened, and 25% of those are severely cost burdened, which means that they are paying more than 50% of their income towards their housing. So when you look at our, we just had the 2024 income limits released by HUD this past week, and according to them, the average median income for Cumberland County or the Fayetteville area is $69,600 for a family of four. And so that means that what we consider low to moderate income is 80% of that, and they've calculated that to be about $60,000 for a family of four. Now, they also released the most recent fair market rates of apartments and housing. So the current 2024 fair market rate for a 2-bedroom house or apartment is $1,292. Okay, so I don't know how many of you know low-income households that can afford $1,300 for a 2-bedroom apartment, but I don't work with any, right? Each year, our developers submit applications to the North Carolina Housing Finance Agency for low-income housing tax credit projects. Y'all probably know those. Those are our United Management, United Developer projects like Spring Lake Green, Sycamore Park, Oak Run downtown on Old Wilmington Road. So those are properties that are subsidized housing, right? And we only receive like one project each year. Cumberland County only receives one LIHTC project each year. So when we're 20,000 affordable housing units short and we're only receiving one project each year that has 48 units or 72 units, it's not going to cut it, right? Okay, so I'm going to stop talking about affordable housing because I could do that all day, right? So a third gap is case management and housing navigation. And basically that comes down to our nonprofits and my department. But our nonprofits just don't have capacity to do case management and housing navigation for the many, many people that they see each day. So those are some of the gaps. So some of the things that we're doing well. So our local continuum of care, and I want to acknowledge Debbie Brown, who is our current chair. I believe the COC has been doing very well in the last few years about bringing our providers together, having regular meetings, trying to identify ways that we can improve service delivery and get our folks housed and pressure people who have the ability to make change in the community. Something else that we're doing pretty well at is equity, and I understand that while the people in the system are disproportionately African American, and then we have a disproportionate rate of Native American also in our homeless system, that once they're in the system, they are pretty equitably going through moving into permanent housing. So our African American population and white population, Latino, they're all moving into permanent housing at about the same rates once they are in the system. So what we have to work on is making sure that they do not get into the system to begin with. We are moving forward on some of our goals from our strategic plans. In 2021, we're doing the Homeless Support Center, and then the City of Fayetteville has the Day Resource Center, which has opened and is working. And then so some areas that we can improve. So we have been doing some landlord engagement with Continuum of Care, And so those are some things that we would like to do more of and improve there, because we have to, with our shortage of housing units, we have to find those landlords who are going to be willing to overlook evictions and criminal histories, who are able to put people into their units at a lower rent rate. We, of course, need more resources. The government's city and county government, we do put resources. We can always put more resources, but we also need resources from the community, whether that's more foundations, whether that's from business, whether that's from individuals. Like I said, our nonprofits need to build their capacity. They can't do that without our community supporting them, either through volunteer or donations. Affordable housing strategies, I already talked about that, and I'm not going to go into too much more of that, but there's 3 things you have to do for affordable housing. You have to have a supply, you have to keep people stable so that if they are low income, at risk, they don't become homeless, and then you also have to subsidize some of these units, because as we said, we just do not have enough affordable housing units for our low income families. And then the last thing I would notice is we can improve on city-county collaboration, and I think that is one of the reasons that we are here today, and I know that the city and county have definitely been working towards that, whether that is in the elected officials or with our city and county departments. So.
Thank you very, very much. It says it's time for me to get summary and final thoughts, but I think you all have heard from me quite a bit and probably enough. I want to open it up to any of the people at any of our key partnerships who may. We have COC.
She has shared with you. I would like to say a couple of things. I'd really like to frame my thoughts around the following. So, Cumberland County, well, we start this way. North Carolina Department of Commerce has designated Cumberland County as a Tier 1 distressed community. For those of you that don't know what that is, Tier 1, Tier 2, and Tier 3. Tier 1 is the most distressed, least distressed is Tier 3. We are in Tier 1. So as we're imagining that, it has already shared with us, we need case management, we need housing navigations. Our agencies are doing the absolute best they can with what they have, and that also includes the lack of funding that they need to be able to have that. We've also addressed the fact that we need emergency shelter beds, but I'll add to that that is a low barrier situation. We've talked about the affordable housing, and I know that we want to make sure that everyone understands that our individuals, our homeless individuals, are at least at 30% AMI or lower. And as David shared with you, what a person makes versus what rent costs, there's a lot of individuals that are at risk and are going to become homeless in the very near future. Also, we need to understand the following 2 areas that have increased in our homeless population. One being the 55 plus, and I will share with you, I was just reading an article this morning from USICH, Jeff Olivet, I think it's how you say his name, that was indicating that 50% of the current population of homeless individuals are those 50 years or older. And that by 2030, that number will triple. Let that sink in. Plus, one of the other 2 areas that we noticed that are increasing are our youth, and our youth coming out of foster care. And what have we got to do for those? One of the other things that I was saying on the COC side is that we need a broader community awareness of what the COC is, what the work that's being done. The COC 501c3 proper is a facilitator of service providers. We have approximately 60 individuals, advocates, faith-based organizations, government agencies, nonprofits that are part of our CFC. So we need for that partnership with our community. Once the understanding is gained, then we need to be able to have a greater partnership within our community. And the last thing that I would share is we talk about the mental and behavioral health care. But while we're looking at that, we have to understand a few things with our homeless individuals. That affects our emergency department, which is used quite often by our homeless individuals for multiple reasons. We're looking at incarceration. We've got a mom with 3 children. She has nothing. She may go and steal some baby formula when she gets caught, right? So we're looking at situations like that. And then we're also looking at substance abuse and how we need to address that within our homes. So as we're thinking about all of these and how we need to move forward, please remember what our community looks like, the real version of what our community looks like.
Thank you so much, Ms. Brown. Thank you to County and Community Development Director. And just reminding everyone as we're going through these pillars, as we're building out this Office of Community Safety, mental health, violent crime, youth intervention, and homelessness. We just had representatives from those sectors here today, so in no way reflecting or overlooking the work of the many, many partners that provide service in this area. We're just trying to figure out what it is that we're doing, facilitate a plan, and that's why we're blessed to have Dr. Tate here today. As a part of this discussion, the City Council and council members, and particularly Benavente and others, have been very passionate about this. We wanted to make sure that this was data-driven. We heard the professionals say that was important. And we pulled together some data points that we would like to share with the community today for the last 3 years of calls for service and which one of these pillars they fall or most relate to. There will be some overlaps, but I want Dr. Tate to talk about that a little bit. And then, we wanted to keep a tight time. We're doing great on time to make sure that we opened up the floor to be able to have some dialogue with you once you have all of the information. But again, this is just one of several meetings and steps toward making sure that we build this out right in a way that's long-lasting and effective to make sure that we are putting the resources where the problem is. So with that, I'll give it to Dr. Tate.
Thank you, Mr. Mayor. I'm going to try to do this as an overview instead of going into a bunch of specific numbers that I don't know off the top of my head that I should have had for you. But when we say data-informed approach, some of the things that I ask are how many calls and or charged crimes are happening for violence-related issues, violent crimes, versus how many calls for services are we getting for mental health calls and supports. I always try to be interactive, as you know. Which one do you think 2 to 1 we have is higher than the other? So whether it's violence crime or mental health calls for service. So raise your hand if you think it's mental health calls. All right, put your hands down. Raise your hands if you think it's violent crime. So actually, this opens up a conversation then. Why do we think it's mental health calls for services over violent crime? Somebody tell me why. Yes? So that there's some overlap between law enforcement responding to mental health calls is what you're saying too, right? Yep. And so on that same token, and I don't want to call her out, this is a question to all of us. So if they say, and again, I'm not speaking numbers from Fayetteville. We're going to go hypothetical. If 3,000 are for mental health calls, how many do we think then are for violent crimes each day, or generally over a year? You think it's less or more? If you think it's more, raise your hand. So I want all the elected officials to see this too. I want the mayor to see this too. Sometimes the perception of crime and violence, sometimes the perception of a problem may be different than what the data says. Right? So far and away, they have more charged for violent crimes than they even do EMS responsive for mental health calls. So what is a violent crime What is a violent call for service? Now, we talked about how oftentimes not addressing the root cause means that there's a lot more calls for service for the police and things resulting in violence and injuries. So, have you ever heard of police getting a 911 call and taking a long time to get there because they have multiple calls they have to respond to? If you heard of that, raise your hand. Okay, so do we know that they have a very, very high call volume? Right. So if we think that those calls are not related to violence, what do we think that it's related to? And this is science to me trying to get public perception too. So what do we think that it's related to then? Police shortage? Okay. So is there any intersection between mental health calls and violent crime? Yep. So, but we think overwhelmingly that mental health calls for service, mental health calls and responses are more than violence. Now, I'm happy to actually hear that it doesn't match the data, but it teaches me a lot of the science around the perception of the issue. As a mental health professional, it makes me happy that that is at the top and the forefront of your brain and not the violent crime. Violent crime is much higher, but the fact that we believe that it's mental health is equally as important to me. And so, do we think that mental health calls for services are more or less in traditional areas where gun violence is most persistent? So, where there is a lot of gun violence, do we think those are areas for mental health calls or other places? If you think it's an overlap between gun violence and mental health calls, raise your hand. If you think it happens elsewhere more than where gun violence is, raise your hand. Okay, I'm going to ask again, because, you know, we got to participate, right? So I'm going to ask again. Do we think, let's go A and B, mental health calls are not where gun violence is happening the most? Who believes that? That it's somewhere else, outside of the areas where gun violence is happening? No, we think that there may be some overlap, right? So if we think it's overlap, then this statement, your belief must be, this statement there must be true. Where we see lots of mental health calls, we also see all other forms of violence and crime occurring. Okay. But not always, right? Right, but not always. Okay, so what I wanted to get out of this discussion is these are the discussions that we need to be having much more. The data says the violent crimes are much higher. Mental health calls are the ones that we're saying that we think, but we think that there is some overlap. All of this is beneficial for you to have the conversation and to think of how do we prioritize our limited resources where they can be most effective. So if I'm wrong, raise your hand, and it's okay. Yes?
If a call goes out to the dispatcher,
yep.
Okay, how do you, when does it get separated or put into data? It doesn't get put into data right then, does it?
So I'm happy you asked that, because the people who can answer that question and go into the question session is here. EMS. Who's here from Fire EMS? So, and it's not to put them on the spot. Sometimes it happens at dispatch. Sometimes they might clear the scene and that happens. You want to speak on it a little bit? Yes, sir.
All right, so good afternoon. My name is Ronnie Willett. I'm the Deputy Chief for the City of Fayetteville Fire Department. And in response to the question how are calls coded, how are calls received, and how are calls classified, generally speaking, when a call comes in, the dispatchers have a priority series of questions that they ask to determine the best and closest call determinant to classify that call in. Once they get that information, they quickly transfer the call to the appropriate type of service expected to respond, whether it's law enforcement, whether it's fire, whether it's EMS, or all three. Once the responders arrive on scene, they confirm the location, and they check on scene, and they go through their appropriate protocols for response, and then they can either confirm or adjust the type of call based off of what they're seeing. And oftentimes there's a different outcome based off of what they're experiencing on scene versus what's been categorized in the CAD system. And so, to your point, Councilmember, there are several sets of data that are being collected along the way. The original call code that was classified at the time of dispatch can be captured, and then the response code at the conclusion of the call, based off of the agency and the way they record the type of service provided, can also be captured. Does that help paint a picture of how these things can be categorized? Is that good?
It's very dynamic situations on those things. So I did not expect that people would think that the mental health calls were higher than violence crime. I'm happy because oftentimes the perception of violence is much higher than the reality. And in this particular group now, we could have some selection bias from our sciences that the people most likely to come to this room may think that versus people I don't want to ask, but I would tell you the question that I would ask if we can anonymize is how many people in this room live in the areas that have the highest rates of gun violence? And if those people may think that that answer to that question may be different, needing to face it each and every day. But this is the point. If we want to follow the data and what the data says, sometimes what the data says may be different than what we're most passionate and what's closest to our heart. Sometimes people come to me, JCPC's here, and say, and Judge, you're here, that the violent crime amongst youth is just out of control. Then I go to the judges in juvenile justice and they're like, I mean, it's a problem, but it's not, but the perception is there, right? And so it is a problem and we need to serve youth much more. But when I look across the state at violence that's causing death and most arrests, somebody tell you think it's juveniles or adults getting arrested more, charged more, injured and killed more by gun violence? Which one? If you think it's juveniles, raise your hand. All right, hands down. If you think it's adults, raise your hand. It's adults. But the perception matters, right? And that is what I'm trying to get to here. The perception matters. But when you're making decisions about millions of dollars, you got to think beyond just your heart or your perception and add in the numbers. I didn't say leave out your heart. I didn't say leave out your passions. I said combine it with what the data is telling us. So if the data is telling us that overwhelmingly the population, and I ain't going to go through it again, but y'all can think about what I said before, right? That population, overwhelmingly, gun violence and violent crime is the leading cause of injury for them, then we should probably focus our time and attention, if we're following the data, on that violent crime. That is not to say, mental health professional, that the mental health calls and crises are not important. In fact, we said there's often a lot of overlap. So I would say yes and. I think focusing on gun violence and violent crime is also focusing on mental health and crisis response. And this is something that I didn't say that I want to make sure I say. Brought up hospital-based violence intervention programs. I've helped start some of them. I have worked in some of them. In Savannah, I used to actually be the one to go to the hospital and support our team. When young people are outside after community violence occurs, outside the hospital where a friend or family member have been killed, what are some behaviors you see from them? Anger, sadness, isolation, grief, fear, revengeful. Is that a mental health crisis? They need a heart team. They need a mental health response to help them stabilize before they go back and do something. So often what we look at as mental health crises, I will tell you, Fire EMS and Chief and them know when they respond to a violent crime where there may have been people killed in a high violence area, they absolutely need to have situational awareness about who and what is happening around that scene. Because oftentimes you're going to see kids in crises screaming and yelling. They need mental health stability right then and there. Not just, and they are important, the people who may be homeless or may be in those other areas who may be facing and may be high frequent utilizers of 911, community paramedic services, and et cetera. Those young people who we identified as the highest risk population, right, and the research is clear that those who particularly hear and see gun violence a lot have adverse impacts that make them much more likely to be involved in crime and violence. Yes.
Hi, I'm Commissioner Veronica Jones. I noticed that you related to saying HARP, which stands for, I know what it means, but I want everyone to know, Holistic Empathetic Assistance Response Team, and I know they're doing a great job of that in Durham, and I know that there's been some talk from the city will be trying to do something similar. So if you could just elaborate a little bit for those that don't know.
Yep. So we know. Yeah. So we know we have. Thank you very much, Commissioner. I appreciate that. Thank you. So we talk about alternative responses sometime, and one of the questions mentions we want non-law enforcement responses sometimes, right, to calls that may be more health focused. And so there are a couple of models related to non-law enforcement, sometimes community paramedics, sometimes mental health clinicians, sometimes credible messengers, oftentimes together, responding to areas where calls may come in and may be diverted, or once they're on scene, they call those alternative responders to come, help stabilize that individuals using their unique skill set around mental health wellness, and hopefully wraparound services and supports long term, which is often a missing gap. Right, and so when I said that we need to expand what we often view as mental health crises to the areas where gun violence is also occurring, what I've seen, and not in the Durham program specifically, more nationally, is those programs don't spend a lot of time in the areas where we say the overlap is, in those areas where gun violence is very prevalent. And so my suggestion, whatever implementation or strategy you want to implement first, that's up to you to decide, is still focus on the highest risk population in the highest risk areas who also have mental health crises that are least likely to show up on your radar. That population we talked about, young black males who live in gun violence areas, you most see their mental health crises where? Somebody tell me. I like this silence. You know why? Because we don't see it. We don't see it. You see it when they get arrested. You see it when they get shot. You see it when they crying out for help and nobody listening. So we often pay most attention to them when their crisis result in violence. What I'm saying is if you want to implement programs for mental health and crises, that same data that said these locations and these zip codes with these young men and this age also needs, and if you need me to provide you the research that supports that, then let's do that. But if you have a mental health response team, a community paramedic team, and they're not spending equal amount of time in those high gun violence areas, then I think you should probably talk to chief and team and ask if they see young people in crisis every day, every week, every night. We're going to go to questions, and I'm going to get to you. Ciara's going to come. Mayor, you wanted to say something? So Ciara will come up. Ciara Scott is the Deputy Director of the State Office of Violence Prevention. We're going to go through some of the questions that came in.
Okay, thank you. So we have a few questions that came from the audience, and so I guess this is just a reminder also, you can still continue to fill out these cue cards and ask questions. And if you need some, you can just raise your hand and they'll come give you one. So the first question is actually for JCPC. There's someone in the audience that would like to just get a little bit more information about what the outcomes of your work look like in the organizations that you fund. So in particular, they want to know how many youth do you reach, and what does the success look like, and what type of programs are involved and available, and how does the community find them? So that's kind of a few questions, but in general, can you just kind of speak to the outcomes of your work and what success looks like?
So the outcome of the JCP program, so there are several programs that are funded under the JCPC. I don't know if you've heard of Fayetteville Ministries Final Friend program, the Career Readiness program. We have the Teen Court program, Communicare, which is the Family and Courts Together program, as well as their Juvenile Assessment Center. We have a program called the Group Theory, which is the Build Yourself program, which Mr. Kevin Brooks is here from that program, as well as Youth and Family Services program. So each program has their own suite of who the youth it is that they're reaching. I believe that most points it is somewhere between 20 to 30 youth in each program per year. It could be more or a little less depending on those referrals that are coming in to each specific program.
Just to add that, that's all right. And I think that there's some, I've been asked to about some of what we talk about is what we can quantify or not quantify. It's kind of difficult. I know the programs do the very best they can to try to provide that to us. But sometimes there's different variables that can't be really quantified on what reaches out to you. So I just want to add that.
Thank you. Okay, the next program, somebody has asked, how is what Durham's Heart model is doing different than how the Cape Fear community paramedics respond to events? So do we have someone here from Cape Fear community paramedics?
Yeah.
Okay.
Yeah.
Here. Oh, there's one.
So I think one of the major differences in this kind of doing what we talked about here, right, is that there's a gap between the plethora of resources we have and the data that we're seeing. And so what Durham was very, excellent about alternative response programs is that they are not just a paramedic or a clinician responding to mental health. That's not what they are. That's a part of what they are. But the biggest piece is that they provide what's called care navigation. And so within 24 to 48 hours, they have a team that follows up with individuals who encounter that alternative response team and connects them to those short and long-term resources. They foster relationships with those people. We heard, particularly the population we talked about are notoriously distrustful of government. And so what they do is they take individuals who have themselves experienced mental health or substance abuse issues and have recovered from that. They put them in the care navigation unit, and the relationships are built with community members in a way that can continuously connect them to short and long-term resources. And I think the holistic approach of alternative response programs are different and what makes them more effective in some of the programs we touched on today.
Can you introduce yourself and say more about your work?
Yes, I'm Jayla. I'm the Director of Alternative Response Program Advocacy at NSPAC.
Thank you. All right, so our next question, someone would like to know, how can small businesses and outreach efforts assist in the efforts being undertaken to address homelessness and food insecurity issues in our area?
So I think and make sure somebody want to end. Go ahead. No, I was going to point to you actually.
Okay.
Yeah.
So the question was small businesses and
outreach efforts
to help homelessness.
Yep.
Right.
And food insecurity.
Okay. So just like with any of our, advocates for homelessness, you can work with any of our homeless providers that are working in the community. Cumberland Community Foundation does a great job each year of supporting our local nonprofits. But they're spreading their money around a lot of nonprofits. So if you need if someone is here from a small business and would like to get a list of our nonprofit homeless providers, I would love to give it to you so that you can donate your time and or resources, do a fundraiser, join the continuum of care, and just get involved with the homeless community network.
For small businesses, we also have a food policy council that is a joint Fort Liberty, Cumberland County Food Policy Council. So our small businesses are certainly, we are looking for members to be a part of our food policy council. And that group is thinking about food insecurity in our community and ways that we can engage, as you've heard alluded to, right? Government has capacity, but not enough capacity to solve food insecurity for our community, right? It takes a community effort to do that. And so we'd encourage our small businesses to engage with the health department, with our social services department, and thinking about ways that we can expand access. We run government programs, and our staff work really hard to do that. But we need more capacity to be able to address food insecurity. So one easy way for our businesses to do that is join our food policy council, come to a meeting, think about how you can, and let us help you figure out how to plug in and where we can make a connection for you.
Thank you. All right, so another question that we have is, what will it take for city and county to have more conversation and unity to support the city together?
Well, that's a great question. We'll take a stab at that. Part of what we were talking about here is the benefit of this meeting today, in addition to hearing from you and having these partners, is to see where we are as a local government. You know, to hear Dr. Tate, I've got notes all over the place, but I was writing to him, I said, what do you think? Because this crosses the line of city, county government. Many of these departments, from the health department to community development to the departments that we have, what do you think if this is a joint city-county initiative? I mean, to bring city, county, and healthcare system to a process that makes sure that we cover everything, because the last thing you want is to create another gap where the city says that's not our job, or the county says it's not our job, and the hospital says, well, this is not what we do, and we still end up in the same situation. So I'm hoping that's why the invitation went out today, that we let the state kind of lead the charge in this, so that local government, we can work together, and it's not about who's in charge. So I think that there's definitely will from many of the head nods that I see from county officials as well as colleagues on city council, that we figure out how it is that we do this jointly to make sure that we deliver a good solution to the community.
All right, thank you, Mayor. So the next question is, when thinking about the data that has been presented here today on a variety of topic areas and looking at the population, do you think the military has changed the outcomes or increased these numbers in any way due to retirees, vets, and active duty members?
So I think, so if we're talking about violent crimes, I'm going to hit a couple of different things. One, I think the VA has been, I'm a former VA hospital social worker, so let me say that my answer may be a little bit biased. I think definitely since I first went to Iraq more than 10 years ago, the VA has done a much better job around veteran homelessness and some of our court interventions, or some of their now court interventions, and kind of a whole of VA whole health supports. I actually think there's a lot that we can learn from some of the ways that the VA has been tackling everything from homelessness to food insecurity to even suicide amongst veterans. The younger population that is coming out may still have some challenges on re-entry. I haven't seen any data that would be driving or increasing violent crime from that particular population. In fact, they have some additional protective factors that other populations do not have, such as access to VA hospitals, oftentimes some guaranteed income if they were injured. There is some special housing programs that are just for veterans. I always kind of say like a Section 8, but for veterans. And they have some very, very low barrier services and supports that we can probably learn from. I don't know if the health department or PDMS, have you seen anything from the veteran population increasing lately that's of note? No. Yeah. So, okay. Thanks.
Well, I think in addition to that, I think that some of what we're doing in our advocacy, and many of the council members and myself go to D.C. regularly to make the case that as a military community, I'll use Mayor Pro Tem's quote about the largest city, largest neighbor to the largest military base.
Largest neighbor to the largest military installation in the world.
So she says that so much like a school teacher that we get it, right? But what we're trying to do is to make sure that we make that case to our federal partners that we have specific problems that come with being the largest neighbor to the largest military base. And so I think part of that, in the mental health particularly, and I'm sure that the data would point to if any of these circumstances point to the population that we have here.
Yep. And Mayor, and I would say I was speaking from veteran population. When we talk about shared risk factors, that warlike violence that I experienced to develop PTSD was far fewer gunfire incidents than some of your residents experience in 10 to 15 years of their life. So I may go 1 or 2 years to Iraq, but where I grew up, I experienced way more incidents of gun violence than I did on 2 deployments. And so I think we also need to look at, from that active duty population, some of the risk factors they have is exposure to trauma, exposure to gunfire, exposure to toxic stress, right? Which is very similar, if not worse, in some of our areas that may be struggling. So I think that those shared risk factors affect me if I live on a base, or like the majority of military families, they live in your city, right? And definitely in your county at a very young age oftentimes. But I just want us to make sure that we connect those two. Being shot at feels very, very similar, if not identical, when I was in Iraq, and as some of the people may feel in the community. In fact, it may be worse, because I got to go back home there and I don't have anywhere else to go, and there's no safe base for me to go to, right? And so I wanted to give a veteran perspective on that. I think when you have so many, like you have a large installation here with Fort Liberty, that it's not just the service members and the veterans, but it's also their families. And most often, my job as a former military police officer and criminal investigator on base was investigating domestic violence and child abuse, which is very high because of the shared risk factors that we're talking about related to untreated trauma. But when you think about veterans and that trauma, I want in that same vein that you think about in some of our communities that's experiencing that for decades instead of 1, 2, or 3 deployments.
But from the bench, what we find in adult services, I think Dr. Washington can back me on that, go into the Department of Social Services, I know from Dr. White that we do voluntary commitments. And when those patients are ready to be discharged and moved to other health care or other resources to get further treatment, we don't have anywhere to place them. We have children, and Ms. Oxenberg can tell you, where we have parents that come to court and say, I don't want this child, I can't handle it. And her social worker set up a building with a 15-year-old for 2 days and we couldn't place them because of his mental health state. And so we also have to look about the places that we're going to place people. Because we have group homes that are being funded, and they're supposed to be level 4 and level 5 group homes to deal with these things, but they come back and say we're not taking that child to risk.
All right. Our next question is, how is the North Carolina state government, and in particular the legislature, committed to supporting social services and law enforcement to minimize youth crime through wraparound services?
We do.
We didn't put that in there, I promise.
Yeah.
Oh, Mayor Colvin, I owe you one. Well, yeah, okay. So it is about budgeting. You know, when I was a young city council member, I reached out across the state and asked experienced managers about budgeting, and they said, you can tell what's important to a community by what's in its budget, what it chooses to fund or not. So if you take some time to look at 500 or 1,000 pages of the budget, some of the things that we've been speaking about here today just are not funded. I mean, we do our best. We put in bills. We ask for funding for certain things, law enforcement, education, early child care, because all of those things impact what we're talking about, and the composition of our state legislature right now has not prioritized those items. Did I say that nicely? Okay. But what I think is important, we're in a short session now, that we have to advocate for these issues. My first long session, I mean, I give 15 minutes to anybody that wants to come to my office, and they advocate for a lot of things, from fish, water, children, cars, everything. Hi, how are you doing? What's your organization? How can I help you? What are your priorities? So you have to show up for these things and walk the halls of the General Assembly and show up at meetings and make phone calls and talk and talk and talk. Because I can be up there advocating and talking till I'm blue in the face for Cumberland County about these issues, but I need you all to show up too in big numbers. And I'm not saying show up one time and go away. I'm saying show up. And when the budget comes out, like the whole world knows, you got to show up and be there. So, you know, these requests do start with me or our delegation. We have 2 senators and 3 House reps, and we do our best to collaborate and submit these requests. And oftentimes we are as disappointed. I can say that Judge King and I have been working to get funding for the Human Trafficking Court. I mean, she's doing an amazing job with that program, and Judge King, you know, we did everything possible to get that funding. We asked every which way possible, but in this, how many billions of dollars is our budget? We couldn't get $500,000 for a human trafficking court that is the only one in the state. Am I correct? We couldn't get that money. So I just need your help, and it's a matter of priorities. Yes, ma'am.
Well, I just want to add to what Dr. Tate said, is part of the work that he was talking about is social determinants of health, right? And so if you talk about where does our state government investing in, we have to invest in public health. We have to invest, those are all public health things that we do. And so investing and putting $1 in prevention and things like Medicaid expansion also impact all of the things, because if you don't have a place to go, if you don't have food to eat, those are all things that public health does, and so we have to put dollars there too. And Senator Applewhite, I've probably called you up about investing in public health, and the General Assembly has done that, and now we need to do more of that so we can address the social determinants of health first and up front, so then we prevent some of these other things later.
Dr. Green, for mentioning Medicaid expansion. So, of course, we passed Medicaid expansion. With that came a $1.3 billion, we call like a sign-on bonus. And what the governor, what the General Assembly, and DHHS is doing is allocating a good portion of that money to behavioral health.
Yeah, absolutely. I was going to bring that up and make a slight pivot. Medicaid expansion now can cover many of the population, many of the highest risk population that we agreed on that the data showed, whereas previously it did not. And what I mean when I say that is many of these young men now can qualify for primary health care and mental health care supports that didn't before at low or no cost. It's up to us to get them in it. It's up to us to get them in it. So we need to get them enrolled and sign up. If they have major health issues that are occurring that could affect the way that they make decisions and their behavior, right? And so we need to understand that we need to get some early health screenings around some communicable disease. They qualify, let's get them signed up and in it. On that same token, the hospitals and schools play a major role, and I know that the state has been doing some investments in mental health care supports around schools and hospital-based violence intervention programs, et cetera. So I'm going to hear a little bit from schools and hospitals if we could.
Okay.
And social services.
You want me to go? You want me to? Okay. Hey, I'm Sam Fleischman. I'm the Chief Medical Officer at Fayetteville Valley Health. I'm also a psychiatrist. I've been in this role about 10 years, and part of the community was born and raised here. I appreciate the focus and where the most, at-risk population is, and really, when they get to the hospital, we're there at a time of a crisis, and often, again, we talk about what we do to do that, but at that point, we have a couple of options of what we can do at that time. But that population, when they're already at that point, really don't want to hear what you have to say in a constructive way. So, I mean, for us to be successful, this has to be done. You're going to have to go to them and find a way where they're going to be able to hear what you have to say. Because when they get to the point where we're at, they really sometimes don't want the care. They live the life they've lived. Through their experiences and the culture they've had because of what they've grown up with and all the adverse events that we've already talked about. So, we're limited in how long we can keep somebody in the hospital and provide them care. And if somebody really doesn't want that, it's hard for us to continue that, or you can't, unless you're going to force them into it. We don't have a way to do that. So we try to support everything, and we need to have, and we talked about C4 earlier, we need to develop a recovery-ready community, for people that need to get in recovery, and we need to start that into the adolescent years, all the way up to help folks easily get into treatment and recovery, along with the mental health support. For the health system across the board, we have the behavioral, the community paramedic program that we support and also help administer. And really think that's a great thing, but once we stabilize them, there needs to be some sort of stabilization place for them to go, and guided stabilization we heard about. We have some limitations in this community to help stabilize those folks, to help get a couple days to find out where they're going to go next. There's limitations there, and certainly I think we can do a better job there. And we can go on and on, but certainly we hospitalize. We have a psychiatric inpatient facility. We have psychiatrists. We have a psychiatry residency, child psychiatrists, lots of therapists. And John Biggers here is our service line director for behavioral health. And we work with substance use and recovery in those areas and try to transition those folks for the full continuum. But again, I think for us to transition this to more of a culture to improve it, you've already missed this. By the time they get to us, they're already into the midst of it. I will say a lot of times, we heard law enforcement and you heard from the fire department and from EMS about what happened. So often they all show up at the place and you have folks doing violent behavior. Sometimes you think of it criminal, sometimes you think of secondary psychiatric illness, and so often the choice is, do you want to go to the hospital or do you want to go to jail? And so we come into those dilemmas and try to find it and try to, work through that the best way we can to decide which way they can go. As far as the children go, you heard Judge King and the rest. I mean, we've had children and adolescents sit in our emergency department for months, not days, months. Children 9 years old, 10 years old, in a 10 by 12 room for months in an emergency department because we have no placement for them because of the lack of facilities. I hear that there's money coming, but I can tell you right now there's not enough facilities in the state, there's not enough facilities in this county to help take care of the mental health crisis we have. So I'll leave it at that. For the adults, it's significant too, but certainly for the children and adolescents, it's extremely significant. The last thing I want to say is on a good note, I know that the health system and our emergency department, our trauma team is partnering with the police department. They're doing a public event on May the 2nd. It's I guess that's what's today? Today's Tuesday, so I guess Thursday night at the Smith's Recreation Center. It's called Stop the Bleeding, and it's a Stop the Youth Gun Violence program. And it's there to bring families out. It's open to the public to show what happens in a scene like this, but also to help educate and get more families and adolescents and these vulnerable populations involved and engaged and educated. Thank you for that.
Good afternoon, everyone. I'm Brenda Jackson with Department of Social Services. And first of all, I just want to thank you all for having us a part of this. And I just want to ditto everything that everybody said, so I'm not going to belabor this by repeating a lot of what has been said. We administer the public assistance programs, child welfare, and adult services programs. We do that for the federal government on behalf of the state of North Carolina. I would just say, as it relates to the question around legislation, I think what we find is we come around the table. I've been doing this 35 years, so we come around. I can't tell you how many of these I've been to. And I think when we get to the table, a lot of our challenges is, I'm just going to call it what it is, bureaucracy. Because we are so tied, just for instance, social services. I mean, funding challenges. My budget is almost, my fiduciary budget, almost over $500 million. But then we get limited in our services tied to funding requirements and regulations and some of the difficulty. We're at the table, but some of the challenges is the rules and the regulations that we're governed by limits what I can do. I can't tell you how many times Dr. Fleshman and I have had conversations, and we finally kind of boil down to, we all want to do the right things, but we also are very much, especially in government, tied by regulations, and our funding is tied by regulations. And don't let something happen, God forbid. We get more regulations, and we get more scrutiny. And so sometimes it's not that we don't want to collaborate, we don't want to work together, sometimes bureaucracy. And then the last thing I will say is this whole idea of capacity building. And lots of times the folks, the boots on the ground, are the less paid people. And trying to recruit and retain good people who want to do this work. If you look at social workers coming out now, they don't want to do government work. They don't want to do social services work. They don't want to do public health work. They want to do private practice. How do we build a workforce to do this work? And everybody does not, I think I heard the gentleman say, everybody doesn't have to be a social worker. We need case managers out there. And then we need social workers out there and therapists out there. But we got to pay them a competitive wage. You're only going to get what you put into it. And if we don't invest in paying these folks that go get these degrees, and we talk about rent that I heard Devin talk about and the cost of living, that's our workforce. That's our workforce. And so we got to start talking about how do we build capacity of the workforce that's boots on the ground that can make a difference. So that's all I would add, again, and ditto everything that has been said.
Definitely would be remiss if we didn't hear from the schools, so we appreciate their presence today, so I'll pass that over.
From a school standpoint, one of the things that it really is really clear today, that everything that is happening with mental health started, they were in school at one point. And so it's really up to the school system to create a good foundation. And we also have cycles of people that have been and had negative experiences with schools. They get older, they have children, and then they don't honor the school system as well. So a lot of times we lose a lot of our workforce because, quite honestly, some of our adults are getting used to really being, really dealing with some tough children. They didn't go to school for that. And, you've got some of our wonderful educators that go above and beyond, and we do whatever we need to do to make things successful. So we just look forward to continuing being a part of everything, because I believe that the school system has to partner with law enforcement and everybody else that's been through the room today, because it really starts with us, not only with the students there, but also with the parents of the students that are there now. So any services we can get into schools and really start as early as possible, we're definitely going to lean into that. So thanks for having us here as well.
Thank you so much. And then wanted to kind of, before I turn back over to Dr. Tate, hear from Mr. Kevin Brooks with the PROVE Project, Violence Intervention and Youth Prevention and Proactive Measures that the city has taken. Last year we used some of the ARPA dollars to kind of stand up a new program, new department. So Mr. Brooks, if you could tell us a little bit about what PROVE is into.
Thank you, Mr. Mayor. Sitting here and listening to all of what's been said today, it's appreciated to hear things said. I'm 54 years old, and I love hip hop, and I'm going to use an analogy from that genre, and I'm going to say this. This is sometimes we have to meet people with the language that others may not understand.
you can't be sure some of the low get high. You may hurt until you cry. You may die. That's kind of sums up the work we do. You can't put it on a piece of paper. I hear a lot about data being driven to say whether we're valid or whether the work we speak to on a daily basis is valid. But it's not sexy work. It's hard to be in a space that nobody wants to be in. It's hard to be in a space to listen to the trauma of people and try to figure out what it is that you can say or you can do to make them understand that you care enough. And although you're funded by the government, that you're not them. And you have to reach as low as 10 years old or reach as high as 45 years old for the same exact problem. So yes, it's something that is, we know we're a pilot program. We understand that community violence prevention is something we do across the nation. I hear a lot of talk about interventionalists and interrupters and people like that. We just came from Congress and I heard it being used by people out in Charleston, South Carolina, and people that are in Nebraska. But their definition and what they're doing is something different than what we do here in Fayetteville, Columbia County. We are working with JCPC because we have to stick ourselves right into the cracks and the crevices of places where people don't want to go, which is essentially where the violence is coming from, or where the misunderstanding is coming from, or where the mental health aspect is coming from. And I heard parents being mentioned and they're not being addressed properly, so we have to start doing parent workshops. My own person on my staff is not college educated, but I was working for 25 years. And I can tell you that our model was we are everything that we are, because we saw every type of person come and go, and come in there and lay it down and see what we can do about it, and move bars. So I appreciate what the city has done to this extent. Obviously, there's a whole lot more work to do. I heard Brent mention CTA. I met Brent, brought him here back in October 2022, if I'm not mistaken. I met this Becky here. I see the Z sitting over there. There's plenty of people in this room that I've reached out to over the last 2 to 3 years to say, hey, look, we understand, we're here. What can we do? We would love to be the one that you got before you got the last one, and 911. We've gone to social work with Columbia County schools, and we understand money is an object, so we work on it. And we're a very small staff. And we can't really increase our staff because we are under the same constraints that everybody else is. And just like teachers, nobody wants to do this work. But we also have this problem. I heard the military being mentioned. And we're forgetting that a lot of these soldiers have fathered kids and moved on. And left somebody here to raise those kids who can't afford to send them to the best school or can't afford to give them the best child care, can't address that mental issue or that substance abuse issue. And another thing, this will be the last thing that I say. We're allowing people to open businesses within 100 yards of every high school in the city, in this county. That's right. The highest grade of being suspended right now in ninth grade. That average rate of suspension is between 5 to 10 days. What do you think they're doing from 5 to 10 days? Definitely not learning. So when you think about commerce and taxes and making money, as far as businesses are concerned, think about the type of businesses that you allow to be in these communities that are starving. Force them to have to go and buy a $5 gallon of milk, and at the same time, you got a whole wall of fruity schemes that kids should not be consuming at such an early age. We had a kid in our program overdose on bacon. Okay? So we got parents calling us and asking us what's the difference between baking and smoking weed. And I'm telling them anything that makes your kids do something they want to do is not an addiction. But we can't afford to give them that within our program. We have to go on community partners and the community resources up. And there's a whole lot more I can say, and I won't do it today, but I will tell you this, that proof stands for proactive, responsible outreach over violence with education. We can't leave out education just because we address violence. And we have to be more proactive than reactive. And I'm hearing a lot of talk about reaction to the problems that we already have. But some of this investment needs to be spent in prevention.
Sir, thank you for that. I didn't speak about CVI as much, though in our office we probably spend 70 to 80% of our time one of some of those same conferences and trying to advocate. And so I will take this moment, and I'm happy you just came. This makes me remember something that I'm really, really passionate about. So CVI practitioners, who I like to call community health workers focused on violence and injury prevention, we rarely, in a traditional public health and public safe space, think about them. But they are oftentimes the ones, give you a true story. Last weekend, Ciara and I was in Charlotte on a corner at a gas station known for lots of gun violence, drugs, sex trafficking, etc. Their group, that is very similar, maybe very similar mission as Mr. Brooks, your group in doing, in proactively engaging with populations, as you said, that we most often are hardest to reach and some people don't want to reach. But that profession and those professionals often have the least amount of investment that we give them. Professionalization, standardization, training, capacity building, and support. So when we think about that, one, there are a lot of federal grants out now, so there are a lot of city and county agencies here now. There are CVI funding that is out. Reach out to me at the state level. We can send you those. Reach out to North Carolinians Against Gun Violence. They will make sure, y'all will make sure they get it. All right, I called y'all. Reach out to either one of us. We will get you the grants that are available right now for community violence intervention and prevention. We talk about funding being a gap. Well, if we all work together collaboratively, there are many grants that are out there that we can apply for together. We should apply for it together. The plan and writing in that narrative should be together. Then the execution of that work should be together. This problem we think is just really, 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 really large. I'm going to end on something to think about, and it's like the majority of the community that we have here is not involved in violence and crime. The vast majority is not involved in violence and crime. The small portion that is, needs all of us to help and support them. So I know we talked about a lot today, like it's like 50, 60% of the community and society. It's a very, very, very small pie. But they need an exponentially high volume of services and supports initially. But if we do what Mr. Brooks said, which is more prevention, we know often who they are, where they live, what are some of their challenges. How about we proactively invest and get resources and supports to those groups and to the frontline workers who support them, right? So we know what works. CVI is one, right? We know what school-based programs work. Oftentimes the teachers may be burning out dealing with young people, but I often say they spend 8 hours in a classroom and 16 hours in a war zone. Which one of the behaviors you think they're going to take on the most? That's a simple math equation, right? So if we want to help the schools and retain teachers, and education is a protective factor, we need to make sure that that time that they're spending outside of the schools is involved and engaged in pro-social activities and supports. So if you're a community-based organization or Parks and Rec or business development or internships, if anybody's hiring or the government may need, the city and county may need to develop their own internship program just for this population. If you leave them to survive on their own in this environment that we're talking about, the young people and young adults, they're going to do what they have to do to survive. And that's what we're seeing a lot right now. I often told my little brother, unfortunately, most of the males in my family have been caught up in the criminal justice system. Nobody coming to save us. Well, I'm hoping now that I made it to this point in life that I can have, that we got a lot of people that was coming. But where I grew up, and many of the neighborhoods you are, there's going to be a shooting. Police EMS going to come. When they leave, who coming to help them? There's a 5-year-old sitting in the middle of the floor and a shooting happened, or a 3-year-old, They're going to cry and scream and maybe run to their parent, right? 5 years later, they 10, 11, and 12, they're not running the same no more. By 13 and 14, we know where it's happening. We know who it's happening to. We know what schools they go to. We know what services that they need. Very small population of people that need the majority of our help and support. If we try to spread out the resources everywhere and not focused on that high-risk population, that pie going to keep growing. Because unfortunately, violence spreads like a disease. That's why we call it a public health approach. I.e., if I'm involved in violence and crime, much like COVID, we remember COVID, if I have COVID and I'm in the house, guess who at greater risk of catching COVID? Likewise, if I'm involved in gang and group violence, guess what? You at higher risk now too. Because that violence will follow. And so how do we use our best practices? How do we work with our health department? How do we work with our schools? The mayor, I'm going to turn it over to the mayor about next steps that we want to do. I want to personally thank you all for being here. I know this is pretty long, but I am most excited about the work done here. As I told the mayor and the council, the fact that the city and the county has come together with community partners, I am very, very hopeful that they will partner together and develop this jointly. That is what I want to leave it on, and thank you all for coming today.
Well, let's give all of our participants today a great round of applause. Again, thank you to all of the participants. These are the institutional stakeholders. There are many, many, many more people in the community. There are the people in the community themselves that we need, that you are included today, whether you got the initial invite or not. I want you to also look around. This is a point of privilege I'm going to use, and I may get in trouble a bit, but it's okay. Look around at which one of your elected officials are here and who is not, okay? And so we are the local government. I thank Commissioner Jones, thank Commissioner Adams, but we need to make sure we hold them accountable to this process. This is not a city of Fayetteville issue. This is our community issue, and we're going to need our partners fully engaged and participate to make sure that we do what you've elected us to do as a body. So thank you. The next steps for the city, we'll continue to have more community discussion. We'll, I'll speak to council and the team about whether they want to move this process around a bit so that we can make sure that we reach as many people as possible as we build this out. We want to get it right. That's our goal. We want to fix this. Dr. Tate, thank you and your team for committing to working with us and helping us build that. Let's give him another round of applause. They have big territory to cover, and so we thank the state for prioritizing that. We're also continuing to work with our federal partners to try to bring more resources and grants in so that we can push them out the door. But remember, elected officials, we all held accountable. Thank you to the judges for what you're doing. We've got to celebrate our wins when we get it. We are seeing a 60 to 70% reduction in violence for 2024. That is because of the collective effort of you, the police chief, the judges, the county, the city, the hospitals. So it is working, and that is a positive step toward it. And so let's continue to finish strong. But thank you for coming. Thank you for spending the day with us, and God bless.